I'm the senior manager of the Global HIV Vaccine Enterprise of the International AIDS Society. It's my pleasure to open timely topic roundtable on the vaccinal effect of monoclonal antibodies. I would like first to welcome all the participants as well as speakers and moderators. The various speakers today will present the immunological processes behind this vaccinal effect in different infectious contexts and in different species. However, it should be kept in mind that its reality and therefore its relevance is still being debated by many colleagues. This point will be undoubtedly be one of the first to be raised during the discussion. As we focus here on in the IS and mainly in the Global HIV Vaccine Enterprise on HIV prevention and cure, the goal of this roundtable is at the end to bring together opinion leaders in the fields of HIV R&D to provide a balanced view literature on the vaccinal effect, discuss its relevance in the anti-HIV immune responses, its potential role in HIV preventive and curative vaccine strategy, and encourage collaboration towards further basic research in this area. The meeting will consist of 3 presentations followed by a roundtable discussion. It's important to note that this meeting is recorded, and by participating, you are consenting to be recorded and for the recording to be used publicly for educational purpose. So let's begin with our first speaker. Our first speaker is Mireia Pellegrin. Dr. Pellegrin is research director at CNRS, group leader of antibodies and immunomodulation in INSERM team in Montpellier in France. 20 years ago, Mireia described the existence of a post-vaccinal effect of monoclonal antibody in mice in different models. The title of our presentation today is An Introduction to Fc-dependent immunomodulation induced by antiviral antibodies. Mireia, the floor is yours.
Great. Thank you very much, Jean-Daniel, for this nice introduction, and also to having invited me to discuss. Can you hear my screen or not?
Yes, perfect.
Okay, I just put in.
You have to put it in presentation mode.
Yeah, okay. Okay, so thank you for this invitation to make this introduction of Fc-dependent immunomodulation of antiviral antibodies. So, in fact, as you might know, the monoclonal antibodies are now the main class of biotherapeutics, and there are more than 130 that have been used in the clinics. However, in terms of antiviral monoclonal antibodies, there are still few of them that are being used by therapeutic use, but they are more and more interested in using them for the treatment of severe viral infections. And the therapeutic success of monoclonal antibodies is due to the multiple modes of action. And it's important to highlight that antibodies and immunological interactions are really a high versatile system. And these antibodies, on one hand, can recognize the target by the Fab fragment, okay? And also through the Fc fragment can really interact with different actors of the immune system. So antibody properties such as affinity, specificity, neutralization capacity, isotype, glycosylation, and so on can really affect the immune outcome. In addition, through the Fc fragment can interact with different actors such as multiple Fc-gamma receptors that can be either activatory or inhibitory, with different affinities for different IgG isotypes, and also differentially expressed on different immune cells, and each of these cells displaying a specific immune function. This leads to a myriad of immune outcomes that can really lead to either the direct control of viral propagation, but also to the modulation of the antiviral immune responses. So indeed, to control viral propagation, it can be done through direct target elimination, either the virus or the infected cells, by different mechanisms, among them, for instance, the complement activation, the lysis of infected cells to antibody-dependent cellular cytotoxicity, for instance, mediated by NK cells, and also by phagocytosis. But in addition, antibodies can form immune complexes that can interact with Fc-gamma receptors expressed in different immune cells, such as monocytes, neutrophil, basophil, mast cells, and can trigger different effector functions, such as the release of pro-inflammatory mediators, chemoattractant chemoattractants or cytotoxic substance. They can also bind to Fc receptor expressed on dendritic cells, and in this case, mediate a better activin activation and better antigen uptake. Sorry, a better dendritic cell activation, a better antigen uptake, leading to improved T cell responses. And they can also interact with B cells and modulate their activation. So through this Fc gamma receptor interaction, antibodies, in particular antiviral antibodies, can induce immunomodulator functions. So as Daniel said before, we have been studying this topic for several years, and if doing that, we have been using a model, a retroviral infection model, which is an infection with an MLV virus. And in early 2000, using this model, we made the proof of concept then that short treatment with a therapeutic antibody, which is the 667 monoclonal antibody, which is a neutralizing one, protect mice in the very long term for more than 1 year. And this protection is due to the development of a protective immunity that composes both a humoral response and also a cellular immune response. So since then, this enhancement of humoral and cellular immune response by antibodies has been reported in other pathological contexts, such as breast cancer, lymphoma, melanoma, but also in viral infections and also in bacterial infections. I don't know if you see the last part, the end of the slide. Okay, it doesn't matter. Okay, so we really wanted to understand from this mouse model which were the mechanisms involved in the induction of this long protective immunity by antiviral antibodies. And the first question we addressed was to study if the treatment with antibody decreased the viral load and in this way avoid the overwhelming of the immune system. So we know now that decreasing the viral load is not enough to induce such protective immunity, because if we inoculate just a low inoculum of viruses, there is no protection in the absence of the treatment. But if we keep the neutralizing effect of the antibody by using a F5 prime fragment of the 667 antibody without the effector functions, thus there is no protection. And if we keep the neutralizing effect with different effector functions, for instance, by the use of an IgM, also highly neutralizing, in this case, again, there is no protection. In all cases, the absence of protection is due to the absence of the induction of a protective immune response. So these Fc-related functions are crucial for the induction of protective immunity, and also the monoclonal antibody isotype is crucial for optimal protection. Second, we explore if the antibody could form immune complexes, allowing a better dendritic cell activation and antigen presentation. And we could observe that dendritic cells activated by either the virus alone or in the form of immune complexes did not induce the proliferation of CD8 T cells. In contrast, when we make immune complexes, this time using infected cells, we could observe a strong CD8 T cell proliferation. And this can be explained because the immunodominant peptide, GAC-L, is present in infected cells, but poorly incorporated into viral particles. In addition, this enhancement of CD8 T cell responses depends on the Fc gamma receptors, because the same experiments done in the present with an anti-Fc gamma receptor, there is not this strong CD8 T cell proliferation. We also extended this observation in vivo, and we showed that the administration of immune complexes done with infected cells could also increase the frequency of virus-specific CD8 T cells, showing thus a role for this type of immune complexes in enhancing CD8 T cell responses. These results also highlight that the nature of immune complex matters, because I have just said that it was the immune complexes done with infected cells, but not with the virus, that is really key for enhancing this CDTL response in Fc gamma receptor dependent mechanisms. But more recent, the group of Gagliardi have also shown that the nature of the antibody itself, in particular, its glycosylation, can also be key to enhancing human immunity, at this time by a complement receptor dependent mechanism, in particular the antigen deposition on follicular dendritic cells, leading to better B cell responses. So I think this immune complex mediated enhancement of T cell responses has been described in different pathological contexts. A lot of studies deals with cancer, but also viral diseases with MLV, LV, CF, HIV, hepatitis virus, and so on. And indeed, there are the immunomodulatory functions of immune complexes, both in vaccine and therapy, have been extensively reviewed in different articles. But I would like to point your attention to a more recent work showing that Fc-optimized antibodies, in which they have been modified and mutated with the GALI mutation that allow Fc-gamma receptor gain of function, allow to elicit stronger CD8 T cell responses, and again goes through an enhancement activation of dendritic cells and better CD8 T cell responses. And now these antibodies with this mutation is being used for the assessment of the antiviral effect in other pathological contexts such as SARS-CoV-2 infection and also hepatitis B. Third, we only wanted to study if this vaccinal effect induced by this antibody therapy were linked to inhibition of the Treg response. And this is an important issue because chronic viral infections are associated with Treg responses, which dampen antiviral immune responses. We could observe that Tregs appear very early after infection, about 10 days post-infection. And these Tregs are able to repress both the cellular and the humoral antiviral immune response in infected mice. However, when mice are treated with the 667 antibody, there is a control of this Treg development. And interestingly, neither the Fab-prime2 fragment of the antibody, neither the IgM neutralizing antibody is able to control this Treg development, showing that this Treg control is dependent on Fc-associated functions. But more importantly, we also show that the depletion of Tregs was able to restore the humoral and the cellular antiviral immune responses. So this shows that this antibody-based immunotherapy prevents the Treg expansion and limits immunosuppressive activity, and also suggests that it will be necessary to control immunosuppressive responses to achieve protective immunity by antiviral monoclonal antibodies. So to sum up the first part of the experiment our work, we identified several mechanisms by which antiviral antibodies can induce long-term protective immunity. So the antibody is neutralizing, so will neutralize the variants, but also will induce the lysis of infected cells through IDCC. It's able to induce a humoral response, and also to induce the CTL response through the formation of immune complexes and activation of dendritic cells. And also it's able to block the development of this Treg response by mechanisms still to be identified. But which is important that in this first part, the antibody is really able to control the viral propagation and to induce this antiviral response. But later on, when the antibody has already been eliminated from the animal, because I remind you, the treatment is only about 5 days, this host humoral response is also able to neutralize the virus, to induce the lysis of infected cells, and continue forming immune complexes with dendritic cells, maintaining in this way an antiviral immune response in the very long term. To go further into the mechanisms, we next study if different Fc-gamma receptor expressing cells other than dendritic cells were involved in the induction of protective immunity. And we also studied in parallel if the different Fc-gamma receptor expressing cells were able to cooperate in modulated antiviral immune response during antibody therapy. Among the different cells, we focus in neutrophils. Why? Because neutrophils are really key effector cells to fight against pathogens by different effector functions, such as phagocytosis, the net formation, but also the release of ROS and cytotoxic granula. But they also have the capacity of producing different cytokines and chemokines that are able to recruit, but also activate different immune cells. They can also play thus an orchestrated role of the immune response. So, in this context, we assess the immunomodulatory role of neutrophils in antiviral antibody immunotherapy. To this end, we perform neutrophil depletion experiments in our mouse model infection with the efficacious virus and the treatment with the 667 antibody. The depletion was done using this highly specific antibody named 1A8 antibody. So as you can see here in open squares, infected treated animals in which neutrophils have been depleted show a decrease in the survival curve. In this survival is much lower than that observed in infected treated animals' proficiency in neutrophils. And indeed, infected treated animals in the absence of neutrophils, they really show a survival curve close to that of infected but not treated animals. So he asked whether this reduction of survival was due to an increase of the viral propagation. And in fact, we could observe that in the presence of the therapeutic antibody, there was no difference in the frequency of infected cells, whether the neutrophils were present or not, showing that the viral propagation is hardly affected by neutrophil depletions in the presence of antibody. We could further show that, in fact, there's not NK cells that are crucial for antibody-mediated viral control, and I will come back to this point later on. So if neutrophil depletions abrogate the protection by the therapeutic antibody, despite having no effect on the viral propagation control, so really suggested immunomodulatory effects of neutrophils. And this is indeed the case, because when we studied the development of humoral responses against FcγRs virus, we could observe that infected treated animals develop a strong humoral response, much stronger than infected but not treated animals, here in red. But infected treated animals in which neutrophils have been depleted, we observe a strong decrease of the endogenous humoral response. And importantly, this endogenous humoral response, the high serum level of this endogenous humoral response correlates to disease protection and really show a crucial contribution of the humoral response in the long-term protection. So we next wanted to study the mechanisms by which these neutrophils have these B-cell helper functions. And we could observe that neutrophils isolated from mice have been treated with therapeutic antibody show an enhanced expression of the B-cell activating factor BAF, suggesting that upon antibody treatment, these neutrophils acquire B-cell helper functions. And this was further confirmed in vitro experiments in which we could observe that Fc-gamma receptor triggering together with interferon gamma stimulation potentiated the BAF secretion of neutrophils. Then we aim identify which immune cell were potentially a source of interferon gamma that could really help this BAF secretion by neutrophils. And we observe that infected treated animals show a higher percentage of interferon gamma producing NK cells as compared to infected but not treated animals. So we study whether these interferon gamma secreting cells were able to potentiate BAF secretion. So to answer this question, we make co-culture experiments using interferon gamma producing NK cells together with neutrophils. And the source of interferon gamma producing cells were NK cells activated with interleukin 12 and interleukin 18. So by making these co-culture expressions between neutrophils and NK cells producing interferon gamma, we could observe a stronger activation of neutrophils as well as a higher production of BAF by neutrophil co-cultures with the cells. And this also was correlated with enhanced activation of B cells, showing thus a key role of interferon gamma NK cells, producing NK cells in the induction of BAF production by neutrophils. So overall, these studies show a key role of neutrophils in the induction of protective immunity by antiviral antibodies, but this is not due to the effect of neutrophils in the control of the viral propagation, because it's mostly done by NK cells, but in the role of enhancing the B-cell responses through the secretion of BAF, leading to better B-cell responses in terms of marginal zone B cells, plasma cells, and virus-specific IgG. They also show that NK cells, through the secretion of interferon gamma, can also cooperate with neutrophils to induce this long-term antiviral protection. Based on this, we really wanted to go further and understand the role of NK cells in antiviral monoclonal antibody therapy protection. Do they have effector or immunomodulatory functions, or both? Again, we use our mouse model in which we perform depletion NK cell depletion. First, we studied the effect of monoclonal antibody treatment on NK cell maturation and the ADCC capacity. By measuring the percentage of the C11b, C27 negative NK cells, which are a marker of maturation, we could observe that mice that have been infected and treated with antibody display a higher frequency of mature NK cells as compared to non-treated animals. We also assess the ADCC capacity of NK cells by using a fluorescence-based in vivo killing assay. And again, we could show that the infected treated animals, the NK cells from infected treated animals had a higher lysis capacity as compared to NK cells from infected but non-treated animals, showing thus that monoclonal antibody treatment enhances NK cell maturation and also preserves the ADCC capacity. So to understand more the role in the viral control in the context of antibody therapy, we perform in this model again the NK cell depletion using the anti-GM1 antibody. And we could observe that NK cell depletion led to an increase in the viral propagation in infected treated animals, and also abrogated monoclonal antibody-mediated protection with a strongly decrease in the survival of the mice. So, as already mentioned, NK cells are crucial for monoclonal antibody-mediated viral control. In addition, NK cell depletions lead to a reduction of the frequency of virus-specific CD8 T cells, as well as a reduction in the virus-specific antibody titers in infected treated animals, showing us that NK cells have an immunomodulatory effects during antibody therapy. And finally, we could also show that the depletion of NK cells leads to the enhancement of the expression of immunosuppressive molecules in infected animals. In particular, we could observe increased expression of CD39, PD-L1, both in conventional dendritic cells and plasmacytoid dendritic cells, and also an increase of CD39 and PD-1 in CD4 T cells in infected treated animals in which NK cells were depleted. This suggests that the lack of control of viral propagation by the absence of NK cells can really lead to exhaustion phenotype of these different immune cells. So to sum up this part, in the context of viral infection without antibody, the virus can lead to the dysfunctional NK cells. We can have an impact on viral propagation, but in the presence of the therapeutic antibody, there is an increase on the frequency of immature NK cells, in frequency of interferon gamma expressing NK cells with increased ADCC activity and enhancement of virus-specific cellular and humoral immune responses. But despite antibody treatment, if we have NK cell depletion, we can observe an increase of the molecules involved in immunosuppressive pathway, as well as a reduced cellular and humoral immune responses. Thus, this animal model really allows us to identify and conceptualize different mechanisms involved in the induction of vaccinal effects. So the short treatment with an antibody can enhance cellular immune responses, but also humoral responses, and importantly also prevent the development of immunosuppressive responses. And this needs the cooperation of different immune cells, each of them having an effect on the induction of the different type of the immune arms. I didn't have time to go into detail. We also have shown a cooperation between neutrophils and monocytes in the induction of Th1 type protective immune responses. So a question now is, these antiviral antibodies directed against human viruses can also induce vaccinal effects? This is still an unanswered question. However, it has been shown that different monoclonal antibodies can enhance host immune responses in preclinical models of respiratory infection, such as influenza and SARS-CoV-2 infection, and also in preclinical models of HIV, and also in people living with HIV-1, in which will be certainly described by the next speaker. However, it's still whether this enhancement of the humoral and cellular response will induce long-term protection is still an open and debated question. And again, there is no the mechanisms, the potential mechanisms involved have not been identified. So I think that now it's clear that neutralizing antibodies are not just simply blocking agents, might also help patients to develop their own antiviral immune response. This antibody-mediated immunomodulation involves multiple Fc-gamma receptor expressing cells and their cooperation, but they also need to get this antibody-mediated immunomodulation. It will be necessary to counteract virus-induced immunosuppressive responses and to preserve or restore the function of main immune cells involved. Thus, better understanding and elucidating these mechanisms can really help to improve antiviral therapies. And just to conclude, some potential approaches that can really help to improve the vaccinal effect induced by antiviral therapy. This can rely on one hand on the antibody properties itself by playing with the isotype of the properties of the Fc receptor, the properties of the Fc fragment of the antibody, but it can also rely on host-directed therapies. But in this case, it will be important to take into account the viral status, the immunological status, and potential host intrinsic factor of patients before choosing which is the best host-directed therapy that could rely with rather than trying to remove immunosuppression or by making administering an immunostimulatory agents. And I think it's really important to mention that it's maybe not enough to step on the gas for this antiviral immunity, but also to take off the brake and to prevent the immunosuppressive mechanisms. And finally, I would like to mention all the different persons involved in this project, in particular, Marc Naranjo Gomez and Jennifer Lambour, who performed most of the data represented in neutrophils and NK cells, and also our collaborators and also our funding agencies, and you for your attention. Thank you.
Thanks a lot, Mireia, for this very comprehensive presentation of the work performed in the murine model. Please apologize, I faced some issue with my connection, so you can't see me anymore. We'll keep the question for the roundtable, and therefore we move to the next presentation. Our second speaker is Dan Baruch. Professor Baruch is professor of immunology at Harvard Medical School and director of the Center for Virology and Vaccine Research at Beth Israel Deaconess Medical Center. Professor Baruch's areas of expertise are quite broad. He's namely internationally recognized for his works on post-infection and post-vaccination immune responses in the non-human primate model. His presentation will focus on SARS-CoV-2 infection and vaccination. Dan, the floor is yours.
Thank you very much. Can you hear me okay, and can you see my slide?
That's fine.
Okay, great. So in the next 12 to 15 minutes, I'd like to give an overview of correlates of protection for SARS-CoV-2. I was asked to talk about antibody correlates and neutralizing antibodies versus other potential immune correlates of SARS-CoV-2. I will not be speaking about the vaccinal effect specifically. We actually don't have any data on that, either for or against that for SARS-CoV-2, although I know that for HIV, the vaccinal effect has provoked a lot of discussion and is considered by some to be quite controversial. But for my talk, I'll focus on what we know about correlates of protection against a different virus, SARS-CoV-2. So our interest in correlates of protection for SARS-CoV-2 started very early in the pandemic, essentially in January of 2020, and we wanted to explore whether there was natural immunity and vaccine immunity for SARS-CoV-2, given the emerging pandemic. So what we did is we set up a rhesus macaque model for SARS-CoV-2 infection, and we used it to do two experiments, one on natural immunity and one on vaccine immunity. So the first experiment on natural immunity basically involved setting up a rhesus macaque model. We infected macaques by the intranasal and intratracheal routes with SARS-CoV-2, and then we observed substantial levels of virus replication in the lungs, shown here, as well as in the nasal swabs after a primary challenge. Viral loads peaked at around 6 logs and were controlled generally in about 2 weeks. If we let these animals convalesce for 35 days and then we re-challenged them, then we saw a very substantial level of protection. Some of the animals had a blip of virus on day 1 following challenge, which may reflect input challenge virus as much as a small amount of virus replication, but really a black and white difference on a re-challenge compared to the primary challenge, really demonstrating the presence of natural immunity. In fact, immunity was so striking in this study that we were unable to look at immune correlates because there was pretty close to complete protection. And we reasoned that so this natural immunity to coronaviruses is a sort of second nature now. But at that point in time, in January and February of 2020, it really was an open question, and it really was not known whether there was natural immunity in human populations to coronaviruses, and we thought the knowledge of natural immunity would be very important for vaccine development for all the vaccine developers throughout the world. Our first vaccine study in this model was a DNA vaccine. It was essentially a homegrown DNA vaccine that was never intended for clinical development, but really was developed essentially as a research tool. And we showed even a simple DNA vaccine made in the lab could raise neutralizing antibodies, and those gave at least partial protection against SARS-CoV-2 challenge. So this gave us our first insight into immune correlates, and we observed in this study that that neutralizing antibody titers correlate with the protection, and specifically the log of the pseudovirus neutralizing antibody titer correlated inversely with the log of the levels of subgenomic RNA in bronchoalveolar lavage in lung or in nasal swabs. So this gave us an insight, an initial suspicion that neutralizing antibody titers would be important for protection for SARS-CoV-2. We then had a collaboration with Janssen and tested their Ad26 vaccine for COVID, and we observed a very similar phenomenon, that the log of the pseudovirus neutralizing antibody titer correlated inversely with the log of viral loads, here shown in the lung, but also in nasal swabs. So now we observe with two different platforms, a nucleic acid platform and a viral vector platform, that neutralizing antibody titers correlate with protection. So this was also, by this time, by mid-2020, this was seen by several other groups and many other groups by the end of 2020 and early 2021. So it seems almost like an open and shut case that neutralizing antibodies are the correlate of protection. But we also observed in collaborative work with Galit Alter that there were many other types of antibodies and not only neutralizing antibodies. And this may this may be relevant for today's discussion, that antibodies are complex populations and neutralizing antibodies are only one potential function. Here, Galit Alter's lab showed in the same cohort of animals that there were many other types of binding and functional antibodies, binding antibodies with multiple isotypes, as well as different Fc functions, such as ADCP, ADCC, antibody-dependent complement deposition, antibody-dependent NK cell activation. And actually, almost all of these correlated with protection. And that's for the simple reason that they all correlated with each other. So in the macaque model, we really were not able to distinguish whether which types of antibodies were protective, because virtually all the antibodies, with a couple exceptions, but most of the different antibodies that were measured correlated with each other. So basically, binding and Fc functional antibodies also correlate protection if you measure them, in addition to neutralizing antibodies. So we reasoned that the antibody correlates of protection would be solidified in the phase 3 studies in humans, with very large correlations in tens of thousands of humans in the phase 3 studies. But we wanted to use the macaque model to do an interventional study to really look at the mechanism of protection and to evaluate whether antibodies really were the mechanism of protection against SARS-CoV-2 challenge. And so we did something in the macaque model that's very difficult or impossible to do in humans, which is a classic adoptive transfer study to essentially try to prove the mechanism. And what we did is we took large plasma bleeds from convalescent macaques, purified IgG, and then used the IgG in adoptive transfer studies into naive macaques, and then challenged the recipient animals with SARS-CoV-2. And we observed that there was a dose-dependent protection by adoptively transferred antibodies. 250 mg per kg of antibody, which correlated with a serum neutralizing titer of about 500, gave complete protection, shown here in the upper left. 25 mg per kg of antibody gave a serum neutralizing titer of about 50 and gave partial protection. 2 out of 3 animals were protected. At a dose of 2.5 mg per kg, which correlated with undetectable serum neutralizing antibody titers by conventional assays, then we did not detect protection, but viral loads were still controlled a bit faster than in the sham control animals. So this shows essentially formally that at least in this animal model that antibodies can protect. And I guess in light of the discussion that antibodies are more than just neutralizing antibodies, the title of the slide really should say antibodies correlate with protection. Although the neutralizing antibody titers did correlate, then of course the binding and other Fc functional titers also correlated because they're all correlated with each other. So here we essentially proved that antibodies could protect. And then the analysis of the phase 3 studies really verified this, that the neutralizing antibody titers shown on the x-axis correlated directly with the percentage reduction in COVID risk. And in the phase 3 studies, the definition that was used was any symptomatic COVID infection. And this was seen with all the vaccines that were studied. So the Ensemble study studied the J&J vaccine, the COVE study was the Moderna vaccine, the PREVENT study was the Novavax vaccine. And in all cases, the neutralizing antibody titers correlated with protection in the phase 3 study. So here we see data in probably over 100,000 individuals. So it really kind of looks like a case closed at this point. So I'd like to actually try, in my last few minutes, I'd like to try to convince you that it's actually even more complicated than this. If we draw a horizontal line on this curve, then we realize that the correlations are positive in all cases, but the lines appear to be parallel rather than overlapping, which suggests that platforms differ. So if we draw a line at 90% protection against symptomatic infection and look at what antibody titers are necessary to achieve that protection, then it appears that the J&J vaccine, Ensemble, requires about 5-fold lower titers compared with the Moderna vaccine and COVE. And the Moderna vaccine, a titer of about 100, gave a 90% protection against symptomatic infection. For the Novavax vaccine under PREVENT, it was about a 5-fold higher titer than Moderna. So it appears that platforms differ. And it at least leads to a suggestion that T cells might also contribute to protection in addition to different types of antibodies. And that's because the J&J vaccine gave the strongest CD8 T cell response, and the Novavax vaccine under PREVENT essentially does not induce a CD8 T cell response. The second issue is that with the Omicron wave over the last essentially 2 years, Omicron has led to substantial increase in transmissibility of the virus, as well as a reduction of incubation period. And these are known to dramatically impact correlates. And indeed, real world data shows that against Omicron, if you have a neutralizing antibody titer of 100, you do not have a 90% reduction in acquisition risk or even risk of mild symptomatic infection. In fact, even titers of 1,000 don't do this. And in fact, even peak titers after boosting really don't give you any substantial protection against acquisition of infection or mild disease. So it's very clear that these correlates, which were proven definitively against the ancestral virus, really do not hold for variants. So as we showed in a very small cohort that we published last year, and I think has been reproduced by dozens of labs with much larger cohorts, there is substantial neutralization escape by the Omicron variants that is really progressive in nature. Substantial escape with BA.1, that was initially reported in South Africa, and then even further escape with BA.4/5, and even further escape now with XBB and EG and the current variants. This stepwise, very substantial reduction in neutralizing titers seen here in a vaccine cohort, people who got the Pfizer vaccine, as well as in an infection cohort shown here on the right, people who got BA.1 or BA.2 infection. And I'll emphasize that any level of Omicron neutralizing antibodies really required a third dose of the vaccine. That in the absence of infection, which would give someone hybrid immunity, then with vaccine alone, shown here under prime, essentially 2 shots of the vaccine, there were essentially negligible neutralizing titers to any of these Omicron variants. The reason why I'm bringing that up is because if you recall about 2 years ago at this time, when the Omicron wave first started to engulf South Africa, then there was widespread concern that it might undo all the benefits of a vaccine, because essentially there were essentially no neutralizing antibody titers with 2 shots of the vaccine. Fortunately, this was not what happened. This is not our data. This is data from Glenda Gray's group in South Africa. And they showed that in the Omicron wave, despite the absence of any measurable neutralizing antibodies, then there was still substantial protection against severe disease. And the 2 vaccines that were rolled out in South Africa were the J&J vaccine and the Pfizer vaccine. For both of these vaccines, at that point in time, they were only given as the 2-shot prime, and nobody at this point in time had received a 3rd shot as a boost. Despite that, and despite the fact that these people essentially did not have neutralizing titers by any assay that we know about, then there still was a 70 to 80% protection against severe disease, as evidenced by hospital admission or ICU care. And even if you're careful about people who did not have hybrid immunity, it is still held. So it appeared that there was a vaccine effect, retained protection against severe disease in a setting where we know that there was minimal to no neutralizing antibodies. So either we have to conclude that essentially undetectable levels of neutralizing antibodies were still sufficient for this stunningly good level of protection, or more likely, we have to accept that immune parameters other than neutralizing antibodies can, at least at times, still provide good protection. And so I think this could lead to thoughts about Fc functional antibodies, trained immunity, innate immunity, as well as T-cell responses. And I would like to try to argue that really the holistic response of humoral and cellular responses are likely responsible for this type of protection that we're seeing. In particular, we spent some time looking at T cells, and early on after the Omicron pandemic, then we together concurrently with 3 other groups worldwide, all 4 groups showed that vaccines elicit highly conserved cellular immunity to SARS-CoV-2 Omicron. Now, this isn't addressing the vaccinal effect. This is really just addressing vaccine-induced T-cell responses. But it was, we think, very important for the Omicron wave, because while Omicron BA.1 and all of its cousins and progeny became progressively more and more neutralizing antibody resistant, then essentially they never escaped from T-cell responses. And this is shown in our data, shown here with 2 different vaccine platforms, the viral vector platform from J&J on the left and the mRNA platform from Pfizer on the right, showing that the Omicron CD8 T-cell responses, shown in green, are essentially unchanged from the ancestral T-cell responses shown in black. And this is true on a per participant basis as well, that the correlations between the ancestral CD8 T-cell response and the Omicron CD8 T-cell response were nearly linear. And this was even more true for CD4 T-cell responses. So to try to prove this, we did another macaque experiment to try to prove that CD8 T-cells were important. So we vaccinated animals with the Ad26 vaccine, and then at week 5, we administered a depleting antibody. So we did an in vivo CD8 T-cell depletion, either with a sham control antibody, isotype match, or a CD8 beta antibody or a CD8 alpha antibody. And then the objective was to see whether CD8 depletion in vivo would abrogate protection against a high-dose Delta challenge. So SARS-CoV-2 Delta in macaques is a strain that gives the highest level of virus replication, and we gave a high dose. So the goal here was not to prevent infection, but rather the goal was all animals would get infected, and to see how vaccine-induced responses, either with or without CD8 depletion, would abrogate this protection. So here is a summary slide from this paper. Both at peak and at day 4, we did show that there was a substantial vaccine effect, and that this vaccine protection was partially abrogated by CD8 depletion. So in the sham controls, there were about 6 logs of virus. In the vaccinated animals that got an isotype matched antibody, there was about 3 log reduction of peak and day 4 viral loads, which is as we would expect. And we lost about a log of protection with CD8 beta protection and about 2 logs of protection with CD8 alpha depletion, really showing formally that at least in this particular animal model with this vaccine and this challenge virus, CD8 T cell responses are important for vaccine protection. So to conclude, I think the data suggests that neutralizing antibodies are very important. There's no question about that. But I would argue that it's not only neutralizing antibodies, but likely neutralizing Fc functional and binding antibodies all correlate with protection against SARS-CoV-2. But it's also not only antibodies, because data from macaques and humans suggests that both antibodies and CD8 cells, and not antibodies alone, are important for protection. And there's certain clinical observations that I think really cannot be explained by neutralizing antibodies alone. CD8 T cell responses demonstrate substantially greater durability and cross-reactivity against variants than neutralizing antibodies. And although the field remains focused like a laser beam only on short-term neutralizing antibodies, typically what happens 2 or 4 weeks after a boost or after an infection, then I would actually argue that the short-term neutralizing antibodies are probably not the most relevant for population immunity, but rather is the durability of antibody responses, neutralizing and other, as well as cellular immunity, that are probably most critical for protection against severe disease with variants. So I'll stop there, and hopefully some of these thoughts might be useful for the upcoming discussions about the vaccinal effect. This is our group. We were able to thankfully hold our first in-person lab retreat in January of this year after 2 years of having virtual retreats, and of course, many people who contributed in these studies. Thank you. I'll stop there and happy to take questions during the discussion period.
Thanks a lot, Dan. Unfortunately, we are still virtual, and thanks a lot for this very comprehensive presentation on the role of both humoral and cellular responses for the protection against SARS-CoV-2 after vaccination. So our last speaker is Ole Søgaard. Ole Søgaard is professor in the Department of Infectious Disease at Aarhus University Hospital in Denmark. Professor Søgaard is well recognized for his translational research in the field of HIV cure, which includes obviously the use of broadly neutralizing antibody. He will present today the evidences that suggest that there is a post-vaccinal effect with this broadly neutralizing antibody used in cure strategies. Ole, the floor is yours.
Thank you very much for that introduction. And I'm going to show you data from HIV and SIV infection, and I think you'll probably give the data to 50 different researchers, and they might come up with 50 different interpretations. So this will be my interpretation of the data. So basically, the question is, can bnAbs do more than a standard antiretroviral therapy? And we know and have seen now from the previous presentations that bnAbs, they can engage innate immune effector cells and facilitate killing of infected cells. We also have seen evidence of bnAb-mediated enhancement of adaptive immune responses. And this is really what I'll try to home in on during my presentation. So the kind of the background for this proposed vaccinal effect is the formation of antibody-antigen immune complexes, because these complexes can cross-bind Fc-gamma receptors and really mediate the effector functions that we're interested in, namely enhancement of T cell responses, enhancement of antibody responses, and also some immune regulatory effects, which Mireia also alluded to. So before we go into the data, I'd just like to kind of try to draw your attention to a bit of the background for why there might be this controversy in the HIV field. So basically, there are different settings where bnAbs can be administered in HIV infection. One background could be in a person starting ART, where there's high antigen viral load, not only in blood, but also in tissues, especially in lymphoid tissues. And here there's plenty of antigen and there's plenty of opportunity for antibody-antigen immune complex formation. And also, if people start ART, there's no risk of resistance development to the bnAbs. In contrast, when we have individuals that are suppressed on ART or are suppressed and go off ART into an HI, there's very little circulating virus in plasma. So usually these individuals are completely suppressed. There's very little antigen expression in tissue also, and the opportunity for antibody-antigen immune complex formation is probably very low. And also there's the risk of resistance development to the bnAbs once the virus starts replicating. So to kind of distinguish between these two different scenarios, I'll try to group the studies into whether or not bnAbs have been administered in a high antigen or low antigen setting. So there's been interest in antibodies as a treatment for HIV for many years. So this is kind of one of the older studies that I was able to identify. Here, passive immune globulin therapy was administered in a SHIV model of HIV infection, and the authors, led by Nancy Hageworth, concluded that indeed there seemed to be some evidence that these immune globulin SIV immune globulin therapy actually seemed to alter the disease profile if administered very early compared to controls. And also they observed some differences in the health of the animals in this experiment. They went on later to try to home in on also the autologous IgG response in these non-human primates, and they concluded that SIV infusion was associated with an accelerated development of neutralizing antibodies in these animals. So moving on to a different studies with monoclonal anti-SIV neutralizing antibodies. This is a study from Japan by Iseda and al. Here they again had non-human primates, and the graphs are a bit tricky to interpret. So basically, the red line are SIV-treated animals, and the black line is a sham control. So each graph is 2 monkeys, 1 control, 1 SIV-treated animal. And basically what you see here are 4 animals treated with monoclonal anti-SIV IgG that achieve rapid control of viremia after challenged, and the IgG was administered 7 days post-infection. And you see this picture in all animals, and later they went on to at least have some indication that CD8 T cells and CD4 T cells were involved in this protective or at least control of viremia during long-term follow-up in these monkeys. So these are weeks at the bottom, so it's at least a couple of years of follow-up. So now in HIV, we have a lot of different bnAbs in clinical development that target different sites of GP120. And I've just highlighted the ones here in clinical development. So there are plenty to choose from. So what is the evidence that these bnAbs can actually also lead to enhancement of adaptive immune responses in a clinical setting? So first here, another study with a SHIV infection with a strain called AD08. This is studied by Malcolm Martin and his colleagues. And first, just 15 weeks of ART administered 3 days after challenge suppresses viremia, as we would expect. But once ART is stopped, the viremia rebounds, as we've seen also in many human studies. So bnAbs can do the same trick. So here they administered 2 bnAbs, 10-1074 and 3-BNC at day 3, 10, and 17 post-infection, and also observed suppressed viremia compared to untreated controls in gray. The animals were challenged indirectly. Upon longer follow-up, they observed that some of these bnAb-treated animals actually achieved complete control of plasma viremia over many weeks of follow-up. They did a CD8 T cell depletion experiment, just like Dan just explained to you. And here the depletions are indicated by black and red arrows. So the black is anti-CD8 alpha treatment, and red is anti-CD8 beta treatment. And what they observed was a rebound of viremia upon CD8 T cell depletion, really suggesting that this long-term control in these animals was mediated by CD8 T cells. So what's the evidence for induction of enhanced humoral responses following administration of bnAbs? So this is a sub-study to the initial phase 1 study with 3-BNC-117 published by Marina Kaski and Michel Nussensweig back in 2015. So this study is from 2016. And here, Till Schofs and colleagues looked at the induction of autologous IgG, neutralizing IgG, at baseline and 24 weeks after administration of a single infusion of 3-BNC. And basically what the different curves show here is the decline in plasma concentrations of 3-BNC. So basically at week 24, 3-BNC is completely eliminated from circulation. So whatever is measured at this time point should be autologous IgG. And what they observed was an enhancement of neutralization capacity of IgG in these bnAb treated participants. So they were viremic at the time of treatment, and they observed, at least those that were off art, an enhancement, and those that were on art, potentially an enhancement, but at a smaller magnitude than those that were off art. And just looking at the data, the different strains spanning broadly different HV clades show an enhancement, in particular among those that were off art compared to untreated controls. And they conclude that the absolute change in neutralizing activity varied between viruses and individuals, and it ranged from small effects to dramatic increases. So this is one of the studies that we have conducted here, also in collaboration with Michel Nussensweig, Sarah Fittler, and many others. It has the acronym ECLEAR, and here we randomized newly diagnosed people with HIV to ART plus either 3-BNC as a bnAb treatment, romidepsin, or both 3-BNC and romidepsin. So 3-BNC was administered at day 17 and 21 post-infection. So because we enrolled these individuals as they were being diagnosed, we didn't have time to pre-screen for sensitivity. And in a post-hoc analysis, we could see that not all individuals that were randomized to bnAb were sensitive to the antibody in this screening assays. It was the PhenoSense assay. About half were sensitive in the 3-BNC group, and in the 3-BNC romidepsin group, about 2/3 were sensitive to the antibody. So these are the viral kinetics after starting ART and receiving the interventions. And as you see, all the individuals are quite viremic, but of course there is a lot of individual variation. So just boiling this down to the 4 intervention groups, we did some mathematical modeling to see if there was any differences in decay. And we actually observed during what we call the second phase of decay, a statistically significantly faster decay in the 3-BNC romidepsin combination group. And when we looked at those that were sensitive versus those that were resistant to 3-BNC at baseline or had persistent viruses, this effect was only significant in those that had pre-ART sensitive viruses. So we also looked at whether or not 3-BNC could enhance elimination of infected cells. So we did this with a flow cytometry-based assay called the FISH flow assay, where we stain for both HV mRNA and P24. So this is just a graph showing the change in HV P24 positive cells, where there's a trend towards decline in those that received 3-BNC-117 at baseline from baseline to day 10. And if we again separate the participants, whether or not they had pre-ART sensitive viruses, this decline in the number of infected cells was significant for those that had sensitive viruses. Again, indicating that 3-BNC actually facilitated the elimination of infected cells at ART initiation. So next we looked at the HV GAG-specific responses. So these are the T cell responses, and they were significantly higher at day 90 and at 1 year after starting ART among those that received bnAbs compared to controls. If we again separated those that received 3-BNC and had sensitive viruses, the effects were even more pronounced in those that had sensitive viruses at baseline, and there was a signal both for sustained GAG responses, sustained and sustained POL responses. So just of kind of interest, we try to correlate the IC90, so the kind of the neutralization sensitivity of the pre-ART plasma viruses with some of these cellular readouts, so the readouts of HV-specific immunity, and indeed there was a correlation between IC90 and the observed cellular immune responses with a higher cell-mediated or HV-specific cell-mediated response in those that had very sensitive pre-ART viruses. So finally, these individuals also interrupted ART, not all of them, but 20 of the individuals that were enrolled in the trial, and they went into this 12-week ATI. If we only look at those that received antibodies, then those that had pre-ART sensitive virus and received a 3-BNC had a either partial or complete response in 4 out of 5 compared to those that had resistant viruses who were rebounded during the ATI. And we have this one individual who has now been off ART for more than 5 years with undetectable plasma viral load. To put this into a Kaplan-Meier curve, it's highly statistically significant, the difference between the sensitive and resistant individuals, but also when we compare those that had sensitive virus and received 3-BNC to all other ATI participants, it's significant, the delay in time to viral rebound. So now let's switch to studies where bnAbs have been administered in a low antigen viral load setting. And there are lots of studies, and I apologize for not having time to go through them all, but this is a study that I think Dan did in collaboration with Gilead. It's a non-human primate study in which they tested 3 different versions of bnAbs, and the bnAbs were administered in Shiv-infected rhesus macaques that had been infected for 1 year before starting ART and then went on ART for 2.5 years, and then they administered the bnAbs, and later they stopped ART. So in this setting, there's very little virus circulating in the animals, of course, because they've been on treatment for more than 2.5 years, and they really observed no enhancement of cellular immune responses against the virus. Also, after treatment interruption, there was control in some animals, but not in all, and it seemed to differ a bit depending on the nature of the antibodies. So the antibodies were dosed in combination with a TLR7 agonist, and CD8 T cell depletion led to rebound in some of the viremic animals, but only 2 out of 7, whereas there was a rebound in all non-viremic animals. So again, it's not completely clear how this control is being mediated and whether CD8 T cells played a role in this particular setting. So also from a phase 1 study of PG121 in viremic individuals, again, there's an antiviral effect of the antibodies that we would suspect, and also development of resistance to the antibodies. So this is a VE3 loop binding antibody, so resistance develops quite easily. It only requires a couple of mutations, and it's seen in all individuals with high viral load at baseline. In those that had low-level viremia, there were actually 2 individuals that went on to control for a prolonged period of time after a bnAb administration. So their viral load was below, or set point was below 1,000 copies. And here they looked at CD8 T cell response in these 2 controllers at day 84 and didn't really see any enhancement. If there was anything, there was maybe a decrease, but it's also worth noting that these individuals had some level of control prior to receiving the bnAbs, and maybe just the decline in antigen levels also led to less kind of stimulation of CD8 T cell responses, but it's all speculation from my side. So another study we did in collaboration with Michelle and also Florian Klein in Cologne was looking at the administration of 3-BNC in viremic individuals in combination with romidepsin. And very briefly, individuals were randomized into 2 groups to receive 2 cycles of romidepsin. And in arm A, they also received a dose of 3-BNC prior to romidepsin. And then there was a washout phase and an ATI. And basically, there was no decline in the size of the reservoir between those that received antibodies or those that only received romidepsin. Whether we look at total or intact HV DNA, there was also no change in HV-specific CTL responses. And when they interrupted ART, there was no kind of benefit of receiving 3-BNC in combination with romidepsin versus just receiving romidepsin. So finally, a recently published study also from our side, has the acronym TITAN, and here we did a placebo-controlled double-blinded study with bnAbs and a TLR9 agonist to see if that could kind of enhance control when dosed into an ATI. And the primary endpoint was time to viral rebound during the ATI, and that was defined as 4 measurements above 1,000 copies per ml. And for the placebo group, there's rapid rebound, as we normally see in these types of studies. For the TLR9 group, there was also rapid rebound, except there was 1 individual that regained control. In the bnAb combination group, or the bnAb group, sorry, there was a delay in time to viral rebound, and there was actually 2 individuals that did not have any rebound at all during the 6-month ATI. And in the combination group, the picture was similar to the bnAb group with a delay in viral rebound. And putting this into Kaplan-Meier curves, there's no difference between TLR9 group and the placebo group, but there was a significant delay, of course, placebo compared to bnAb. And 4 out of 11 participants did not rebound did not fulfill criteria for rebound during the ATI. There was also a statistically significant difference in rebound between the combination group with bnAbs and TLR9 and the placebo group, with 1 individual not fulfilling criteria for restarting ART, but there was no difference between the 2 bnAb groups. So just of note, and when we talk about immune modulation, we actually observed a slightly faster decay in the levels of the 2 bnAbs when they were dosed in the presence of a TLR9. So maybe these kind of immune modulators like TLR9, TLR7 actually stimulate innate immune cells and reduce kind of the cycling of the antibodies. At least it was a slower half-life. Of course, the emergence of plasmauremia might also have played a role here. And finally, we looked at HV-specific T-cell responses with the AIM assay. We saw maybe a slight trend towards an increase in HV-specific immune responses in those that remain suppressed on bnAbs with plasma viral loads below 50 copies. This is at week 13, but in general, increases in HV-specific T-cell responses coincided with the emergence of plasma viremia in not only bnAb-treated individuals, but also in, of course, the placebo-treated individuals. So again, there was no clear kind of signal of an enhancement of CD8 T-cell responses, but maybe some weak signal. So there's been plenty of combination studies now with 2 bnAbs dosed for a longer period of time. So this is 3 doses. This is the study from Michelle's group with Pilar Mendoza being the first author. Again, here they confirmed that in those with a sensitive reservoir, there's long-term suppression of the virus and virus rebounds once antibody levels decline. But again, they see a couple of individuals here that do not have viral rebound after the levels of antibodies have declined below suppressive levels. And this kind of picture with some individuals, usually 10-20% remaining suppressed after bnAbs have waned, have also been seen in a couple of other studies. This is 2 more recent studies. So in the Gabler study, they also had a couple of individuals that maintained control after bnAbs have disappeared or washed out. So just kind of to conclude, some my conclusion is that there's some evidence of a HV bnAb-induced vaccinal effect. So I think this is most clear in the high antigen setting, where studies generally have shown Fc-gamma receptor-mediated boosting of adaptive immune responses. The magnitude seems to vary both between studies and between settings, but also between individuals. So some individuals seem to have a greater benefit than other individuals. In a low antigen setting, studies generally show limited or no Fc-gamma receptor-mediated boosting of adaptive immune responses. But it seems that there might be some individuals that have a benefit. Again, it's difficult to pin down because often it's only a few individuals, but it does appear maybe some individuals have an effect, but it's something that is very open for discussion and interpretation. So I think I'll finish my presentation here, and we'll take questions during the panel session.
Thanks a lot, Ole, for this review of the literature, including your own works. I think it will provide quite good basis for discussing the existence and impact of this post-vaccinal effect during HIV infection. So let's move to the discussion roundtable. We have here two moderators, Dr. Elise Landais from Yavi Neutralizing Antibody Center in San Diego in the US, and Dr. Colin Avner-Doughton, who is director at Vir Biotechnology, also in California. Before we start the roundtable, I just want to remind you that you can either use the raise your hand function, unmute yourself and ask directly your question, or put it in the Q&A box. So Elise, Colin, the floor is yours.
Thank you, Jean-Daniel. Hi, everyone. So thanks to the presenters for those great reviews of the field. I think you've all mentioned, and then Jean-Daniel also in his introduction, about the possible controversies of that is raised with this data. So if we take a step back on this, like I think it's important to come back to the definition itself of vaccine effect. So I will open the floor to you guys to comment on what you would define as a vaccine effect per se, in comparison to what we would see in a natural infection situation. Maybe I will take the presenters in order of their presentation. So we'll start with Maria.
Yes, this is really a good question. I think we have to make the difference between what is the induction of host immune responses, either humoral responses or T-cell responses, and really a protective immune response, which is not the same. Because I think one of the controversial points is that in some patients, it has been observed that really a kind of boosting of either antibodies or CD8 T-cell responses, but it's not really, in the end, really a long-term protective immunity. This is the big difference, I think. That's the main point.
Ben?
I think definition is very important. There are people who have quite strong feelings in the field in either side, some that are very strong proponents of the vaccinal effect and many who are not. And I do think that having clear definitions would be very helpful. For example, it is, I think, very clear that administration of broadly neutralizing antibodies to persons living with HIV, either who are viremic off therapy or who are on therapy and then stop therapy, does lead in a fraction of cases to long-term virologic control. I think that is quite clear with studies from a number of groups. And so if the induction of long-term host control in the absence of antiretroviral therapy that is induced by broadly neutralizing antibody administration, if that's the definition of the vaccinal effect, then I think it's not that controversial, because that is clear that that happens. If the definition is more strict, that the vaccinal effect is the broadly neutralizing antibody binding to virus, leading to immune complexes that then act as antigens to trigger further humoral or cellular autologous immune responses, then I think that that requires further thought. And some of the observations seen in primates or humans that do show long-term virologic control as a result of administration of antibodies may or may not be due to that mechanism. So if you define the vaccinal effect as the specific mechanism of immune complex formation triggering autologous expansion of T and B cell responses, then I think it becomes harder to argue.
Mariah, you want to come back?
Yes, in fact, I completely agree what you have been saying by Dan. I think it's for a long time we assume that this vaccine-like effect, wherever you define it, just the boosting of T cell responses or the long-term protection, is mediated by antibody immune complexes and dendritic cells, but there are not really evidence that show that. I think has been assumed, but I think has not been formally demonstrated. I mean, in patients, of course. So I think this is the key point. So it's important to understand what is, I understand the difficulty at how the antibody can really modulate, and we will probably not only affect dendritic cells, but more widely the function of different immune cells. I think this is the complexity and the beauty at the same time, so the difficulty to highlight it where or not there are these vaccine-like effects.
Thanks, Mireya. Actually, just to comment also, because Colin and I were discussing in preparation for this roundtable, that in our work that we did for regarding the bnAb development during natural infection, we have made observations that are consistent with some of these mechanisms as well, where elevated level of IgG, anti-HIV IgG or anti-GP120 IgG were correlated with the development of bnAbs. And also Colin in one of his papers showed like the higher level of germinal cellular activities was associated to that as well. So it's kind of all consistent observation. And then like you were mentioning, like the definition is how these mechanisms are related. I will go back to Ollie, if you want to comment on that question as well regarding the definition.
Yeah, I totally agree with both Dan and Mireya that it's tricky, and a better definition of what we refer to as the vaccinal effect would be helpful also in terms of avoiding a lot of the controversy, because if we at least can agree on the definition, then maybe we can also more objectively review the data. So I think at least as someone who does clinical trials, I think one thing I struggle with is how to demonstrate the vaccinal effect in humans, because we cannot do CD8 T cell depletion. So really the mechanism of control in those that control is really hard to pin down. And of course, we're all trying to wrap our head around how to demonstrate the mechanism. But that's one thing. So just proving the vaccinal effect, if whatever we agree is a vaccinal effect in humans, is not easy. And then I think from a more practical perspective and a future perspective, just figuring out how we can take advantage of the vaccinal effect in the HV cure field, I think is super important. And that's really what I would like to know, is how do we move this forward? Because we have these kind of small signals in some clinical trials. We and others have tried to combine immune modulators with bnAbs to try to enhance these antibody responses, and we don't see the enhancement that we're hoping for. So maybe that's not the way to go, but then it would be great if we figure out what would then be the right way to go. So I agree, a better definition, but also kind of some consensus on how we're going to define observations of vaccinal effect in humans would be fantastic.
I would add one perspective also, that we might want to broaden a discussion. I mean, today's discussion was about the vaccinal effect, but as a field, we might want to broaden the discussion about host-virus balance. Because if one adopts the strictest definition of the vaccinal effect, which is that either autologous or administered antibodies bind to virus creating immune complexes that serves as the antigenic trigger for induction of autologous humoral cellular immunity, we might actually be missing on other potential mechanisms of virologic control. For example, in either macaques or humans, in some cases, antibody-mediated viral suppression, either early acutely or later on, or a delay of rebound could be sufficient to trigger autologous induction of T-cell responses, or alterations of the host pathogen balance, host virus balance, that is not really due to that mechanism, but still has the long-term outcome of the bnAb administration leading to long-term virologic control. And the molecular mechanism, while interesting, is probably secondary to the clinical outcome that we do see in some cases long-term control. So I would suggest that once we really develop a definition of the vaccinal effect, whether it's narrow or broad, that we might actually want to think broadly regardless of what the definition of the vaccinal effect is, because otherwise we might actually be missing out on the mechanism of some or even most of the phenomenon we're looking at. And the debate as to whether the vaccinal effect really exists or not might be missing the point of the fact that we see positive clinical outcomes, and we should try to explain them, whether or not it's because of that mechanism.
Yeah, I would completely agree with that statement and what Oli and Maria were also saying. I think the key question for the field is why people after bnAb treatment don't rebound. Why those individuals, right? That's a complete mystery currently. But one of the hypotheses that I think has been, somewhat with a leaky definition, as we've been discussing, is the vaccinal effect. But I would offer it up as immune engagement, right? So some form of immune engagement between the antibody and the virus that then leads to a state of being able to control the virus. And that may not be able to be possible in all individuals because of different states of the immune response, as Maria was talking about in her talk, or different impacts on the viral fitness in one way or another, based on actually the neutralizing antibody portion of the molecule. So I think there's obviously a lot to unravel, but I really echoed Dan's point about let's not miss the big question, which is what is the mechanism of control in the individuals after bnAb therapy. That's really what we're after. Vaccinal effect and engagement of the host immune response might be one of the mechanisms. It might be a contributor, but there very well may be others as well. So following up on that discussion. Oh yeah, sorry, Maria, go ahead.
No, I completely agree with that, and I also wanted to come back to a comment has been done before about these host virus balances, because yes, I think we have to be taking into account this potential enhancement of immune response, but I think it is also very important the viral control, because this viral control will really maybe allow to avoid to spoil or to really compromise the immune system. And I think it's really this host balance, the host virus balance, which is very important. And in this case, the control of viral propagation is also really a key factor that can also be important to further have this induction of a more protective immunity. It's probably a very holistic aspect on that.
Thank you, Maria. So maybe exploring a little bit more something that Oli alluded to is kind of where do we go next? How do we explore that? The ability of the host to control the virus after bnAb treatment in of course, in a minority of individuals. So let me ask the panel, would it be useful to do a study that would be using, I'll give you two different types of studies. So an HIV infected population, you treat with a broadly neutralizing antibody, or you treat with a broadly neutralizing antibody that's been knocked out for effector function. And a second type of study, maybe alluding to some of what Dan talked about in the SARS-CoV-2, which would be a neutralizing versus non-neutralizing antibody, both with effector function. Would either of those studies be useful in helping to maybe not define, completely prove the vaccinal effect, but at least move the field in a direction that would be positive?
I can go first. So I think that's a great question, Colin. And I think for people like me who do clinical trials, the question is often comes down to what can we access. So what's actually accessible in terms of GMP material. So these studies can be done in humanized mice or in non-human primates. But to do it in humans, you need GMP products, which is really expensive to produce, and many different companies or institutions have these bnAbs, and some of them are very restricted in terms of how much they can engage in kind of these academic industry collaborations. So at least from my perspective, I love to do studies where we look at different types of bnAbs. Either we could have a LALA mutated antibody, so the Fc function is more or less completely removed, or we could have antibodies with enhanced functions, such as the gaily mutated antibodies, and then really, have a randomized trial, have 3 different groups, and then try to pin down the cellular immune responses, but also, of course, have many other outcome measures that we look at, and then see if we actually observe a difference or if there's no difference at all. Because I think, again, looking at the studies in non-human primates is not at all clear to me how this is mediated. There was a study with a LALA mutated PGG121 by Stephen Ken and his colleagues in Australia, and really they had difficulty showing a difference, but then again, the setting in which the antibody was dosed was also not optimal for really looking at a vaccinal effect or enhancement of adaptive immune responses. So that'll be my kind of 2 cents. So I'd love to do the studies, and I think they will actually more or less be needed to have more conclusive data from humans, but getting access to the product is the main hurdle.
Okay.
Maria, would you like to comment?
Yes, well, I think I totally agree. It's very much more difficult to work with people living with HIV, of course. And I was just thinking about the relevance of working with Fc-muted antibody, because we know that you really need all the functions of antibodies. You need to have these polyfunctional effects. So, and I think this is really very important. I have to really think about the ethical issues about using an antibody that maybe we know that because they don't have other effector functions, really maybe not as efficient as a wild type antibody. On the other hand, I would like also to comment, that's why I insisted about the immunological and virological status of patients, because I think this might be an important point, and we can take some lessons from vaccinal studies with some clinical vaccine trials in which we may have a kind of correlation according to the type of endogenous human response, but also in terms of Fc-gamma receptor polymorphisms. And I think maybe trying to not to better stratify, but maybe to better understand the immunological profile of some of the patients can really help to have a better idea, which can be the correlates of some immune characteristics in terms of the induction of this host immune response.
Dan, would you like to comment before we go to Sean Daniel?
Sure. I think that there are experiments to do. And in many cases, the non-human primate model might be the right model to do that. It's unlikely we'll be able to make mutations of antibodies for the sole purpose of addressing a scientific question as part of clinical development. So in non-human primates, we do have that possibility. And so I think those experiments should be done. And we should sort of not bring our bias to those experiments, and we might be surprised in the outcomes, or maybe the outcomes will be as we suspect. But I think there is knowledge to be learned, and so we should do those experiments.
Jean Daniel.
Yes, I don't see any question in the audience. So let's come back to human. If we believe that there is an effect related to the antibodies and mainly to the Fc parts, are you aware of any kind of studies on the role of on the study of the polymorphisms of the Fc receptor on this effect? Could some particular polymorphism may explain the difference we observe between the different patients?
I think that this kind of studies has not been done in the context of the study of the induction of vaccinal effects. However, there's a lot of studies done in the effect of Fc-gamma receptor polymorphisms and HIV progression. This is true, but not especially in the case of the induction of vaccinal effects. But it's clear that this Fc-gamma receptor polymorphisms affects HIV progression.
Right. So do you know the frequency, say, of the V158 F158 variant in the Fc gamma 3A receptor? Do you know in the population in general, is it very common?
I think it's quite common.
The low affinity, yeah.
Yeah, I think it's quite common. This polymorphism of Fc gamma receptor 3 is quite common. There is other polymorphism on the gamma 2A receptor also, and I think this is less frequent. But yes, for the V1, the one you mentioned, 148, it's really, I think it's quite common. I don't know exactly the frequency, but it is common.
Yeah, from the studies I've seen, it's usually something like 2/3 low affinity, 1/3 high affinity, or maybe it's 3/4, 1/4, something around there. And that's easily the biggest kind of biological difference that's very clearly reported in the literature in terms of different Fc receptor genotypes. There's been a good amount of work published in the cancer field looking at genotypes with some very kind of dramatic responses first reported, and to my knowledge, maybe a little bit less clear as studies have gone on. But there are groups out there pursuing cancer immunotherapy, of course, with antibodies directed at killing tumors that have modified Fcs to try to engage Fc receptor gamma 3 mostly by altering the glycosylation of the antibody. Yeah. I wanted to come back to this idea of kind of the context. So thinking maybe a little bit more like narrowly, as Dan was saying about a definition of the vaccinal effect. So if we really think about it, if we think about the question of can antibody help to induce adaptive responses, right? That might be the most strict sense. And then whether those adaptive responses are ultimately responsible for control, say, of HIV or other viruses later on is kind of a separate question, but just induction of the responses, this idea that was discussed in a couple ways. Oli was talking about the presence, kind of the amount of antigen in two different situations in the HIV, and Marie was talking about the some differences she's observed with virus versus infected cells, right, in terms of what was kind of the important immune complex. I guess the question is what can be learned there, and what would kind of be the next types of experiments that could further tease that apart about what's the most important antigen, along with the in complex with the antibodies for the vaccinal effect. Maria, do you want to comment first?
Yeah, I think this is a very important point, because I that's why I really wanted to mention that the nature of the immune complexes matter, because it's clear that the genetic repertoire of infected cells is not the same as the virions. This is the first point. Not in the context of immune complexes, but just the fact that in the context of just infected cells has been shown to be more efficient in activating plasmacytoid dendritic cells in the case of HIV infected cells, but also there has some studies showing that infected cells in the context of hepatitis activate more efficiently dendritic cells. But these studies were not done in the frame of antibody. But this is the point, that each type of antigen, it's really inducing or different signaling danger signals, and can really affect the immune outcome. But it's also important, as I mentioned at the very beginning, the complexity of the system, because on one hand you can just play with the antigen, but you can also play with the properties of antibody itself. And in this case, you can just play with Fc normal or mutated glycosylation, because in this case glycosylation will really affect the immune response, but in this case by exploiting the complement system. So I think it's really a matter of either the antigen, but also the properties of the antibody itself. And in this case, the complexity can be not only at the type of Fc receptor, but also glycosylation patterns and the different functions we have, and the interaction with different actors of the immune system.
Thanks, Maria. Oli, did you want to comment?
Yeah, I think that's actually a study that could be done. What you're proposing, basically to have a not a large, but a bigger than what we've done previously, a clinical trial with two groups. So these could be either, as we did, newly diagnosed individuals with HIV that are due to start ART anyway, and then they're randomized to early bnAbs with ART or just ART, and then basically measure cellular immune responses, and once antibodies have washed out, also humoral responses in this setting. So I think that can be done if we need evidence. So there are, at least to my knowledge, 3 different trials that are about to start with bnAbs at ART initiation. So there's an HGG trial being conducted in the US. There's an HGG trial co-funded by Bill and Melinda Gates Foundation, due to start in sub-Saharan Africa with 2 bnAbs at ART initiation. And then there's the French Riviera trial led by ASIA, which has been close to starting for a while now, and hopefully will start enrollment soon with again 2 LS bnAbs at ART initiation in early treated individuals. So I think these types of studies where it's randomized and it's blinded can really help kind of provide some more balanced and well designed and well kind of executed data and samples that can address this question of whether or not there's actually some induction of adaptive immune responses. So of course the challenge is that when you're dealing with humans, they are not all infected with the same strain. It's a lot of different strains we're dealing with. Sometimes it's subtype B, sometimes it's all kind of subtypes, as it was in our case. And then when you want to do your assays, you kind of have to take into account these differences in strains, the diversity of the virus. And then, there are no validated pan subtype reservoir assays that you can do with intact provirus. And then you have all these issues. But I think at least for adaptive immune responses, it can be done.
Yeah, this is something I wanted to ask actually earlier. Like everything that you presented, there was a lot of data on polyclonal responses, whether on plasma or on T-cell responses themselves. But how well characterized have those responses been in terms of cellular, really single cell data? The way we do that in the vaccine field itself, if we're talking about vaccinal effect, in the vaccine field, we really look in details into epitope mapping, really characterize the repertoire of these responses. Has it changed before and after the treatment with the antibodies? That would really go back to the definition that Dan was talking about. If we really talk about really specific engagement and priming of the immune responses, what are they? Have we primed something new? Have we boosted responses from before? Yeah.
Yeah, I think that's a great and very important question. I think at least in this setting, again, we have the challenge that we're trying to boost. Not when you have vaccine, you have some epitopes that are vaccine-induced epitopes that you can look for. When you have a response towards a swarm of viruses in a patient, there are lots of different epitopes that are being targeted. And again, you're looking for enhancement of maybe either some of the dominant responses or the subdominant responses or both. And it's kind of just more murky. It's not as clear as when you have like well-defined epitopes that you can measure responses to. But I mean, it can definitely be done, and we're doing some work to try to get some better data from some of the studies we just completed.
Maybe I can follow up with another question, thinking about, I think that, Ole, as you're saying, of course, it's really hard to tease out specific mechanisms in humans. But in animal models, we have a bit more of a chance, especially with Maria and Dan's work. One of the things I've thought about, I'd love to get all of your perspective on is that so in HIV, obviously, we're entering a chronic infection, right? With existing antibody and T-cell responses. In many of the animal models, we do those experiments mostly because they're easier, quicker, and more well controlled in basically naive animals, right? So the antibodies are given very early after infection. And I wonder if part of the reason we're seeing potential differences or interpretation is kind of those two settings. And I think, Maria, it's something you brought up during your talk, is kind of the context of the state of the immune system actually matters a lot as well. So any comment there, and any ways you guys could think about kind of bridging those those two systems?
Yeah, I think you're right. Of course, with the animal models, the treatment is quite early. And it is important as the rapid induction of relatively rapid induction of immunosuppressive responses. I think this is an important point, coming back to the patients. On the other hand, you can also maybe think about how can be addressed this question in the context of HIV infection, for instance, with early diagnosis of HIV, or for instance, just after post-exposure of HIV, or even also in infants. in way to know that mother, to avoid the mother to child transmission. So in this case, maybe we'd be interested to see what happens with an early treatment in these cases, and when we can try to mimic a little bit this early phase of infection. And I think it's maybe an important point that has to be considered, try to mimic this early infection in these conditions, for instance, mother to child transmission or exposure to virus with precise identification of the moment of exposure and so on. But it is clear that when you go to a chronic infection, there is a huge modification of the immune system. And it's known that NK cell function there's some kind of dysfunction of NK cells during the course of HIV. If you rely on NK cells, but there is an NK cell dysfunction, even if it's not completely abrogated, but it's not as efficient as it should be. So all these kind of parameters has to be taken into account, and maybe try to restore first the function of these cells in the context, of course, of chronic infections, of which the virus has been there for many years.
I think it's maybe time, Colin, that we call on also on the audience a little bit. We've kind of grilled our panelists quite a bit. I see we have like a few people in the audience who might want to comment. I see Christian Moore, Susan Zola-Pazner, or Stylianos in the audience. If you guys want to comment, or anyone else honestly want to take the mic and comment on everything that we've discussed so far in terms of definition, what could be done, how can this be leveraged to translation into intervention, what new experiment can we define into our studies can we design to answer some of these questions.
Maybe while we're waiting, we did get one question for Oli in the chat, which is kind of, what are you thinking about for next clinical strategies in terms of induction of the vaccinal effect, or maybe more importantly, the induction of viral suppression?
Yeah, so just looking at the whole HIV cure field broadly, I think there have been many different strategies that have been tested. And the only strategies that have provided, at least my opinion, some signal of effect are bnAbs. So LRAs, immune modulators, all vaccines, etc., they have not really provided any evidence of inducing control. Whereas bnAbs, it seems, maybe in a subset of individuals, usually it's around 10 to 20%, there's long-term control after dosing. So I mean, to me, bnAbs are the best tool we have right now to continue with. There might be something that is a lot more effective just around the corner, and then we can move on to that. But I think for now, bnAbs are the most promising tool we have in the toolbox. So it's a matter of figuring out how do we use these antibodies smartly, and then, as we've been discussing, how can they be modified to maybe facilitate the enhancement of adaptive immune functions or whatever functions that we're trying to enhance. How can that be done? And these new antibodies brought forward into the clinic. So I'm thinking a lot about how do we use the antibodies that we have in a more kind of clever way. And I think, at least based on the eClear data and some of the preliminary data from the Rio trial, in which bnAbs are also in one group dosed as individuals restart ART, there also seems in that study from preliminary data to be some effect of bnAbs at ART reinitiation, again in this high viremia setting, which I have speculated might facilitate this effect. So settings like that, where are antibodies most likely to be effective when you test them in a clinical trial? I think that's the key question. And the next question is, what can we combine them with?
So really, yeah, I agree. Definitely the kind of one of the probably most fertile areas to probe is a larger group of patients that would have different attributes, right, in terms of viral load, in terms of host immune responses, and you alluded to, and there's already been some work published in non-progressors that have, or in people that are partially controlling virus with bnAbs. And so additional exploration there, I think, would be quite nice. It looks like, yes, Elise, your request to the audience has worked. Maybe Maria, did you have something?
No, yeah, I just wanted to follow up with the comment of the use of antibodies in combinatorial approaches, because if I just mentioned that monoclonal antibodies are really more than 130 have been used in in the clinics, but they are more and more, particularly in the field of cancer, there are more and more used in combinatorial approaches. That there really needs some combinatorial approaches to enhance the efficiency of monoclonal antibodies in other fields. And I think we maybe have to have a look at how these combinatorial approaches can improve the efficacy of other monoclonal antibodies in other fields, and maybe exploit some of these approaches also in the field of viral infections. Because finally, cancer and viral infections are very difficult, but some immunosuppressive effects are common, whether in cancer or in or viral infections. So I think that probably the most suitable combinatorial approach can really help to develop better antibody-based therapies, as is being done now in the field of cancer.
Thank you, Maria. So we'll go on our audience. I think let's start with Susan. Do you want to comment here on what has been said so far? You can unmute, I think, now. No, maybe not.
Hi, excuse me, can you hear me?
Yes,
We can.
Right. Sorry, I've got a cold. So I just put a question in the chat box, which I'll pose now, and that has to do with the focus of the HIV vaccine field, almost the laser focus, to quote one of the speakers, on inducing broadly neutralizing antibodies. But the field has been quite unsuccessful to this point in inducing broadly neutralizing antibodies with a vaccine, either in animals or in humans. Simultaneously, it's been shown that non-neutralizing antibodies, monoclonal antibodies, have a number of Fc-mediated effects. And I'm just wondering if the people on the panel can comment about whether they think it would be a useful exercise to look more closely at non-neutralizing antibodies as potential effectors, both for use in passive immunization and as targets of vaccines.
Well,
yeah. Go ahead, Carl.
Thanks, Susan, for jumping in. I think good questions. The two things that pop to mind, one is that the mechanisms that can prevent infection, right, in a vaccine setting may be different than the mechanisms that are important for suppression of virus long term. They may be overlapping, they may be completely different. I don't think we have lots of opinions out there, but I don't think we have really definitive answers. And the second, I think I alluded to it in terms of non-neutralizing antibodies, especially in kind of the infected subject setting. I was alluding to that a bit during one of the earlier questions. I myself would be of the opinion that it's probably if you can have the neutralizing aspects of the antibody, I'd prefer that. But I think it's at least reasonable to think about an experiment with a non-neutralizing antibody that might give us some insights into the mechanisms that are at play in terms of viral control, if we're comparing that to a neutralizing antibody.
If I just may add, then one of the questions that were presented to us as we did this study with bnAbs at our initiation was, well, why do we propose that bnAbs work better at inducing adaptive immune responses than the autologous antibodies that are abundant in people that have been infected for weeks or months or years? And I think that's a really good question, because there are lots of non-neutralizing antibodies and maybe even some neutralizing antibodies in these individuals. So why would bnAbs kind of be better at mediating this effect? So I think it's something we can definitely discuss, and I'm not an expert at all, but I mean, there could be several reasons. So one could be that the bnAbs have, or the virus has not yet escaped from the bnAbs, whereas it has probably most likely escaped from the autologous antibodies that are circulating. So that could be one reason. Another reason, as we kind of saw in our data, was that the strength of neutralization by 3-BNC actually correlated with the virological outcome or the immunological outcome. So it seemed that the more sensitive the virus was to the bnAbs, the greater the effect was on the T cell responses, which I think is kind of interesting just in terms of the strength of binding maybe between the target antigen and the antibody. But I assume there must be people who have looked much more into this than I have. So this is more just clinical observations.
So if I could comment, I agree in terms of passive immunization that it's better to use an antibody that has all the functions, neutralization as well as non-neutralizing antibodies. But in the context of active immunization, preventive, prophylactic immunization rather than therapeutic, then I agree completely with Colin that there may be different mechanisms that are at play. In that case, looking at neutralizing antibodies in experiments, maybe in monkeys, should include both neutralizing antibodies and non-neutralizing antibodies, again, in the context of where we are in vaccine development, which is in the absence of a vaccine that's giving us good neutralizing antibodies. I just want to underscore some results that have come out in the last year or so, which have to do with the studies of immune correlates in vaccine studies. So as I'm sure you know, the only independent correlate of reduced risk in the RV144 vaccine trial was antibodies to V2, which were non-neutralizing antibodies, but which we know now mediate a number of Fc-dependent effects. In fact, now there are two studies that are published or have been presented of the HVTN 702 study and HVTN 705, where it's been shown that there's also a correlation of protection with V2 antibodies in one of the studies in the context of T cells. So it is the only signal that we're getting now from multiple human vaccine trials that non-neutralizing antibodies are playing a putative protective role. And it's in that context of finding that signal in actually four different human vaccine trials. And I didn't mention HVTN 505, which also suggested a role for V2 antibodies. So I worry about the vaccine field zeroing so much focus on only inducing broadly neutralizing antibodies and only proceeding to phase 2-3 trials if you have a good neutralizing response, when there are other signals that suggest that non-neutralizing antibodies with Fc-dependent functions may be very helpful.
Thanks, Susan. And maybe I can jump back over to based on what you said and some of the things that Dan introduced as well. I'm remembering, jump over to the cure space. I'm remembering a paper, I believe, from Michelle Newsensweig group that actually showed that it seemed like non-neutralizing antibodies were useful in kind of the context of a broadly neutralizing antibody response to further restrict kind of the escape mechanisms that the virus would have from the broadly neutralizing antibody. So I think, again, kind of it comes back to this interplay between a number of different immune responses, and kind of hopefully the best of all worlds would be to induce all of those types of responses, including T-cell responses, to solve the really challenging problems. Danielle.
Yes, unfortunately, I think we have to stop. I'm quite pleased that we end this discussion with the fact that we need also to look at non-neutralizing function of the antibodies. So I would like to thank you all of us, the presenters, the moderators, the attendees, and obviously the IS for organizing this roundtable. It seems that at the end, the reality of this vaccinal effect has still to be precisely determined, but I hope after this webinar and all this discussion, you will have more data to form a more precise idea on this topic. A summary report will be published at a later date, and so you will be informed, and then have a good rest of the day. Bye, everyone.
Thanks, everyone.
Thank you very much to all of you.
Thank you.
Great engagement here. Thank you.